We want to welcome everyone tonight. We're very excited to have you all with us to discuss the MiniTC Adipose Processing System. Tonight, we are very fortunate to have two esteemed guests on the panel, Dr. Mitchell Scheinkopf and Dr. Ariana Demers. They'll be discussing the basic science behind microfat, lipoaspiration techniques, clinical indications and evidence, and business relations, all of which will be followed by a Q&A session. To make this webinar as interactive and beneficial to you as possible, please load any questions you may have in the Q&A chat at the bottom of your screen. Again, we'd like to welcome Dr. Mitchell Scheinkopf, who is a board-certified orthopedic surgeon based in the Chicagoland area, having over 37 years of experience in joint replacement surgery before transitioning to regenerative medicine. For his pioneering use of computer-assisted navigation, minimally invasive techniques, and hip resurfacing methods. His global impact extends beyond surgery. He has traveled extensively as a visiting lecturer, educating audiences worldwide. Additionally, he has authored over 70 publications in prestigious journals, solidifying his status as a leading authority in orthopedics and regenerative medicine. Dr. Ariana Demers is a board-certified, fellowship-trained orthopedic sports medicine surgeon. She is the past president of the Interventional Orthobiologics Foundation and is a sought-after educator and trainer in orthobiologics and ultrasound. She has successfully transitioned her rural practice away from commercial insurance to focus on holistic orthopedics. At this time, we'd like to go ahead and pass the time over to you, Dr. Scheinkopf.
Thank you. We'll get our slides going here. We'll try. Almost there. Okay, here goes. 2/3 of my way through an orthopedic life, toward the end as director of the joint replacement program at Rush, it was time for a change. I became the first orthopedic surgeon to join the Regenix network and the first lead. The departure was the result of my having completed a clinical trial with a newly introduced MFAT product called Lipogems. That trial was subsequently published as Safety and Efficacy of Percutaneous Injection of Lipogems Microfractured Adipose Tissue for Osteoarthritic Knees. It was published November 19th, 2018. I observed in my practice an increasing number of patients under age 55 who were requesting a total joint replacement. They were inviting trouble. That's one of the reasons I entered the world of orthobiologics, seeking a way to postpone, even possibly avoid a total joint replacement. Second, patients were looking for a total joint replacement when they had grade 2 to 3 osteoarthritis. Next were those with advanced osteoarthritis who were managed well with anti-inflammatories, physical therapy, and who still were able to ski, play tennis, golf, and so on. For those with polyarticular osteoarthritis, I ultimately observed that 3 or 4 joints could be managed in one city, especially with MFAT. Then there were those whose comorbidities precluded them from having a total joint replacement. Lastly, the patient who had joint replacement and had a terrible experience and didn't want to go through yet another surgery. What are our options for patients described above? One is PRP, platelet-rich plasma, in its most recent highly concentrated leukocyte-rich format, allowing for more than 5 billion platelets to be injected in one sitting. Next is protein concentrator ATM, which really adds to satisfactory outcomes of patients treated along with super concentrated PRP. The ultimate standard has been defined. Protein concentrate alone works under proper indication, and most recently, MFAT. That's what this webinar is all about. Of course, BMC has been the standard of care, both intra-articular and intraosseous until now. There's a misconception about fat. It serves not only as a thermal regulator to keep you warm when you ski, it's a complex organ that's a warehouse of anti-inflammatories, cytokines, adult mesenchymal stem cells, precursor cells, and so on. If you review the slides in front of you, you'll get a better appreciation for the purpose of fat. It's an organ. Once again, fat serves as a complex cell depot with the stem cells housed in the vascular niche, MSC effectors that includes macrophages, lymphocytes, etc. The extravascular content includes the differentiated adipocytes and extracellular matrix. So what is MFAT? You have to hear it 3 times. It's microfragmented adipose tissue. It's fat-containing stromal cells preserved in their native niche. Take a look at the slide in front of you for a moment. As far as regulatory guidelines are concerned, MFAT is autologous when prepared with the MiniTC methodology. It's minimally manipulated, and its use is homologous in nature. Why microfat? It's rich in autologous regenerative cells, providing a structural matrix as well. MFAT produced with the MiniTC is applied to the areas of injury or inflammation and produced by the mini processing and with minimal damage to regenerative cells while being produced. So now we'll let Dr. Damiris tell you how to do the liposuction aspiration and prepare the MFAT using the MiniTC system.
Hello, everybody. Thank you so much for joining us. I really appreciate it. And this is near and dear to my heart. I love MFAT, not only for what it can do, but it really is very rewarding for my patients. And everybody's happy to get rid of a little extra fat, if we don't mind. So, adipose is a major source of adult stem cells. Microfat is rich in the autologous regenerative cells. It also provides that structural matrix for reconstruction, healing, and regeneration. And it can be applied to a number of different locations for injury or inflammation, even for aesthetic indications as well. And so it's quite versatile. It can be used in our sports medicine applications, for aesthetics, for wound healing, because it does have that stem cell in its native niche. And it's like an apartment building. It's a very happy little cell in its native niche where it grew up. So we love your fat. This is great. So our solution is this MiniTC. I've been using it. It's a point of care for device, and it really does give you consistent, gentle processing that preserves the cells as well as gives you a very high quality injectate. It's portable, it's disposable, it's closed loop, and it's easy to use and inexpensive. And it can be used, again, for orthopedic conditions. It can be used for other wound healing conditions, and you can use it for tendon applications, joint applications, and it is quite versatile. So the very specific design actually allows for improved injectate quality because of the way that it is processed and washed. And we get rid of those toxic oils and bloods. Typically, this is how our clinic setup is. It's a small footprint. It does have a centrifuge. It's centrifuge based. We have it all comes in one box with the aspirator and the infiltrator cannulas, as well as the entire processing kit. So you don't need anything extra. And really, the reason I fell in love with this is because it starts from the harvest. It is really important to have the right cannula choice, the right aspiration pressure. And so this negative pressure syringe design for 400 nanograms, millimeters of mercury is really important. You don't want to have too much pressure. And we get these large fragments or, as I said, maybe I tell my patients, they were flaking off small little pieces, and we're not blowing these apart, right? These small little frequent flakes, and we use tumescence anesthesia and tumescence hemostasis to decrease the oil and the blood from the harvest, so we can actually get more from our lipoaspirate. Now, when I talk to patients about this, it's not a liposuction. That is a cosmetic procedure. This is a lipoaspirate. We are using tumescence anesthesia to numb and liquefy the fat, and then gently sucking it out under manual pressure. So this MiniTC addresses a lot of critical points. We have a disposable cannula that is fast and efficient and takes the right size bites out of the adipose. The syringe design shows adequate pressure, but not too much. We get extensive washing, which eliminates the detrimental red blood cells and neutrophils. And then it's gently fragmented. And so it's liquid without the oil, which can be toxic. And then we have standardized times and forces, no manual variables, no mixing, no shaking, no going back and forth, and it's closed. So it's nice and safe and sterile, decreasing that risk of contamination. So what is tumescence anesthesia? This is what we use, and this is how we harvest our fat. So we need a sterile field. I use ultrasound guidance to identify if there's enough fat, if there's enough tissue that we can harvest from our patient. We then use normal saline with lidocaine and epinephrine. We use a little 11 blade. You can use an 18 gauge needle, but it seems to be easier and a little bit slicker and smoother if you use an 11 blade for a small little nick in the skin that is then closed with a steri-strip. No need to stitch it. And then we need our harvester and our infiltrator. Usually we inject about 200 mLs of tumescence fluid for each site that is going to be harvested. I use the abdominal site as my primary harvest site. This has been shown to have the highest quality in a number of studies, and lots of people have a little extra fat in their abdomen. And then critical is the minimum wait time of 15 minutes to allow the epinephrine to constrict the blood vessels, so we have limited contamination with the blood. So what we're going to do, what you need that vac-lock syringe, manual pressure, negative pressure, our harvest cannula and infiltrator, and then a little bit of patience, because we do want to make sure that we're not injuring the soft tissue, and always make sure that suction is activated, and I'll go through that. So we love your fat. Now, how do we get it? So let me run you through this video, and we're going to just run you through. This is my setup. Yes, he wears a baseball cap, and we've got our ultrasound guidance, and we're going to just run through how I set this up. We're just going to do a little bit of a nick in the skin with my 11 blade right here, and just a tiny little nick. It's been previously anesthetized with a little bit of lidocaine, and then we have a sterile setup. And we're going to go ahead, and I do harvest on both sides for cosmesis, so that we don't have a divot on one side and the standard lump on the other. I'm drying up our tumescence fluid, and so we have this tumescence fluid, and we're going to connect it to our infiltrator. This is the metal infiltrator. And this movement, the quick rotational movement allows those infiltrators to kind of pass by the fibrous tissues without damaging any of the blood vessels. And then I do this under ultrasound guidance. I'm actually going to go to the next slide and I'll show you how this is done. This is me. Yes, it's during pandemic and I've got like 5,000 masks on so you can see. But what we're going to show you is that now under ultrasound guidance, we're inserting the infiltrator underneath under a visualization. And what you can see is there's 2 layers of fat, and we really like to make sure that we're getting adequate infiltration throughout the site. And you can see that fluid and there's not too much pooling or pockets. And so I'm going all the way in and then infiltrating small aliquots of the tumescent fluid throughout the tissue to have a nice uniform area of tumescence so that we don't miss any place and it's fully anesthetized, and it can be done under just a local anesthetic. So I use the ultrasound for the infiltration to make sure that it's all uniform and completed. We make sure that we don't have any unknown hernias or anything that would be unsafe. And so I think this gives you a nice realm of safety. And you can see we're infiltrating that lower layer of the soft tissue. If you have somebody who's morbidly obese, I am going to recommend that actually the upper layer of the subcutaneous tissue seems to give better quality of the tumescence. So next slide, this is going to be our tumescence anesthesia, and this is going to be that ultrasound guided that we just did. This is the harvest. And so I'm going to go ahead and just give you this. Obviously, we still have this anesthetic, and you can see this area is blanched, and we wait until that area is blanched, and I feel confident and comfortable that the entire tumescent region is now ready for harvest. And then we're going to just do that twisting motion, gently placing it inside the tissue. I then check the level, and I make sure that I'm in that fully tumescent level. And then what we do is then do a manual memorization of the depth of the cannula so that I can then, we're going to activate that negative pressure. And then it's sort of like playing the violin with a gentle back and forth motion to be able to flake that tissue off without causing too much trauma. And if you don't feel like you have a good suction, go ahead and just reactivate. If you don't hear a nice suction when you leave the tissue or the skin, then that means that you either lost suction and you have to just reactivate that negative pressure syringe to be able to harvest your tissue. And so that is how we do our lipoaspirate, and it's pretty straightforward. It's very well tolerated by our patients. They say that it feels maybe like riding a roller coaster where the stomach feels a little bit of wiggly, but from uncomfortable or discomfort, it is between a 1 and a 2 tops for my patient. Usually they feel nothing, and the biggest issue is the nick in the skin. All right, so here's our protocol flow chart. So we have that lipoaspirate. Then what we do is we have the 50 mLs of that lactated ringers that we add to the MiniTC to wash. It's a 5-minute centrifugation to wash the fat. It removes the anesthetic. It removes the cell debris, the RBCs, and the oil. We then pull that out. It comes to the bottom and we pull out the wash. We then rewash with another 100 mLs of lactated ringers, and it's a 10-minute centrifugation for liquid phase separation. And what we have at the end is this gorgeous injectate, and these are distinct adipose clusters, 92% viability, and really this preserves the vasculature, and we have about 1.5 million cells per ml. And to calculate how much you may want to harvest, it's about a 40% to outcome ratio. So if you want 40 to 50%, so if you're looking for 10 cc's or 20 cc's, if you're going to do multiple joints, you would like to harvest 40 cc's, 50 cc's of the tumescent liquid phase from the patient. So you want that raw product to be about 50 cc's if you're looking for about 20 to 25 cc's of injectate. And so that's just a little quick math. I personally am an over harvester. I have not had anybody who is upset that I took more fat. And so I just don't want to have to go back if I didn't quite get enough for what I was looking for. And, people's fat is variable. Some of that loose areolar fat is harder to concentrate, and so you do need to take more. The denser fat seems to be more viable and give a better outcome, easier to harvest, and gives quite a bit better outcome ratio. So just be aware that there are different kinds of fat. If we can go for the more densely packed fat, I think you're going to get a better outcome. And then looking at the MiniTC, we get quite a bit of cells when we compare it against the Tonnard's NanoFat or the other filtration devices. We do get a number. This is a total output, and this is 20,000 per cc for the NanoFat. This is 0.005 million per cc for the filtration devices, and this is between 0.8 and 2 million per cc of injectate with that MiniTC. So this is really nice to make sure that you know that you have a high viability and with a very high cellular content for this device. So, and when we look, we just went through this study with a body jet, which it was looking like maybe this was going to be a really great harvesting technique because you don't have to do the infiltration and wait. It's the water and harvesting at the same time. Unfortunately, we weren't able to get as many of the actual cellular content based on what we were looking at. It was a very, very low CFUF, which is the culturing of the stem cells themselves. So ultimately, I think it's a great option, and I'm going to turn it back over to Dr. Scheinkopf to talk a little bit more about who we should use these for. So thank you so much for paying attention. I really appreciate this opportunity, and I'm looking forward to seeing who is going to best benefit.
Okay, next slide. Oh, here we go. Go back. Okay. There are a few exclusions for use other than patients with a history of active cancer, receiving chemotherapy or recent radiation, or certain prescription pharmacologics. Several comorbidities, such as inflammatory arthritis, preclude usage, so an ESR and a CRP may help clarify when there's doubt. While a BMI of 35.0 had been a cutoff, it might have to be revised before we run out of patients, because there's few patients who come in under 35.0 today. MFAT may be used for direct treatment of the inflammation associated with osteoarthritis, or as an adjunct to an ACL repair, a rotator cuff repair, spinal surgery, etc. Let me share with you the results of several clinical studies that we have performed using MFAT. The slide in front of you describes a study on the shoulder. It was It was prospective, it was non-randomized, it was single arm, safety and efficacy in using the MiniTC device. We treated and addressed osteoarthritis and rotator cuff disease. Inclusion and exclusion criteria are listed. And I'll let you take a second just to review it rather than read it to you. So take a look at what's listed in front of you to see what we selected to include in the treatment in our study and who were excluded. And you could pretty much on your own figure out who is not to be included in the use of MFAT. Next. The pathology treated was grade 2 to 3 glenohumeral osteoarthritis with rotator cuff pathology ranging from low to high percentage as defined by the MRI. The treatment was as you see it on the right side of the slide. That is a single 10 ml dose ultrasound guided injection of MiniTC created MFAT. The total nucleated cell count of the injectate averaged 15 million. It was generated, as you know now, at the point of care. So, the slide before you also describes the demographics of the patients and how they were treated. There were 21 patients, 8 males, 13 females, ranging from age 58 to 80, with a BMI average of 29.6. Once again, everything was generated, as Dr. Demir said, at the point of care. The adipose tissue was harvested, as she described in the film. The patients were treated with 10 mLs of MiniTC processed MFAT, injected under ultrasound guided, with a total nucleated cell count of 15 million. So the outcomes as described were consistent with improvement in patient satisfaction. The average baseline pain score pre-treatment was 6 out of 10, at 12 months, 1.08 out of 10. There was no correlation between the pain score and the degenerative disease grade. The pre-treatment quick dash score, in which no disability is graded as 0 and inability to use at 100%, was calculated at 60.2 on average, diminishing statistically to statistically significant 18.8% at 1 year. The functional shoulder score average was calculated at 47.4 pre-treatment. The functional score had improved by 32% in the first month and reached 81.8% improvement at 12 months and 88% at 18 months. With that improvement continuing at 12 months and for several up to 18 months. The Western Ontario Osteoarthritis Shoulder Score improved 40% in the first month and demonstrated statistically significant 75% improvement at 12 months. In summary, for the shoulder, MFAT deserves your attention because of the patient satisfaction, the symptomatic improvement, and the upregulated functional capacity. This is preliminary data. We're continuing to monitor these patients, and the ongoing study and long-term evaluation will be reported in the future. Now let's take a look at the knee. 36 patients meeting our inclusion criteria were recruited and treated with an average 9.4 millimeters of fat per joint. 48 patients were treated in total, obviously 12 bilateral. One of the wonderful advantages of MFAT is the opportunity to treat more than one joint at the same sitting. You could do up to 3 or 4 joints, 2 knees, 2 hips, a couple ankles, a couple shoulders. It lends itself to multiple treatment opportunities that's not available to you with PRP or with bone marrow concentrate. And even if you take on 2 joints with PRP or bone marrow, it gets quite expensive. So we documented statistically significant improvement in the Coos Junior scores and WOMAC scores in this population of patients. The average dose in the knee trial included 9 million total nucleated cells per injection. You could take a look at the scores rather than my reading to you, but the facts in front of you speak for themselves. I'll give you a second. Okay. So in conclusion, we observed that the clinical efficacy in our knee study actually increased or at least remained stable through 12 months. We conclude that the FAA delivered a quick and lasting anti-inflammatory response. This study is ongoing and we'll look forward to further evaluation in the upcoming months. Next. If you want to have a chance to review the whole story of adipose tissue for musculoskeletal disorders, make note of what you have in front of you. This article was recently published and is available online. Okay, Dr. Demers, your turn again.
Dr. Schreinkopf, are you wanting to share the cell content, or you're not wanting to share that quite yet?
No, it's overwhelming.
Yes.
This
Yes.
is something Nathan can explain more easily than I can.
Great, great. So that was great. That study, the shoulder study, is near and dear to my heart, and we are continuing to observe those patients. And it's quite overwhelming and shocking to see the significant decrease in pain and increase in function. It's really, when I talk to my patients, I always feel like it's kind of magic, but turns out it's not. It turns out it is our own body's cells helping to regulate and direct repair and decreasing that inflammation, really moderating and your immune system to actually change the output from inflammatory to non-inflammatory. So that's been so great. Lauren, do we want to go ahead and open it up for some questions at this point, or do we want to discuss a little bit of business and how we talk to our patients? I do have a question about some protocols. How do we want to do this?
Yeah, I think if you have information regarding business, then to certainly go into that. I think we have a little bit of time. There were 2 other questions that came in as well. So I can definitely dive into those once you cover that.
Great, great. Yeah, so one of the questions that I always get is, this all sounds great, and this seems like it's a good option, but my patients won't pay. Nobody in my clinic's gonna pay. And so then I always get this question, like, how do you talk to these patients? How do you pick these patients and speak to them? And so, part of what I talk to them about is the outcomes and who can benefit. And we need to demonstrate value for our patients to be able for them to understand what they can achieve with surgery, what they can achieve with MFAT, what they can achieve with platelet-rich plasma, and what they can achieve with standard conservative therapies such as physical therapy or bracing and that kind of thing. And so we use the data that was just presented to give them an idea of what they could expect, that they can expect a 5-point pain drop out of a 10-point scale. Now, when we talk about that, that is valuable. And when they increase their function from 40% to 80%, that's significant, and that's a game changer. And so even if we talk to them that it's not going to be a 0 pain, but if we're dropping it 5 points, we're going from a 7 out of 10 pain to a 2 out of 10 pain. That's valuable for my patients, for your patients, for everybody's patients. And then the other thing that I talk to people all the time about as physicians, we have not been educated on how to discuss price and how to discuss money. And when we're first getting into this and we're like nervous about talking about it, it is uncomfortable and it feels uncomfortable. And so my first recommendation is, number one, practice saying it over and over. Because if you come off that you are unsure or you're worried or you're not, well, I guess we could maybe try this kind of, experimental, maybe kind of treatment, and it's kind of expensive and I don't know if I really think or believe in it. Well, of course your patients aren't going to want to consider this as a valuable treatment. That being said, if you know your literature, you know the response, you know what to expect, and you say, hey, we've got this great treatment that gets you 5-point pain reduction for over a year, 18 months, 2 years. We'll be coming out hopefully with that data here shortly. And we can improve your function without surgery, lower risk. Would that be worth it? Can we return you to your function? And they say, well, yes. And I said, well, obviously, unfortunately, your insurance company doesn't believe that this is an important treatment. This is not covered by insurance. It is considered experimental still, even though we've been doing it for years. And it's, $3,500, $4,500, $6,500. And when would you like to schedule? And then stop talking, because there's no reason that we need to justify or explain how we got to that price. Just as when you go to the grocery store, the price of bread is $4. That's just the price. You need to make sure, if you value that, if you're starving to death, you're going to pay $4 for a loaf of bread. Maybe you want to pay $6 for the fancy whole wheat with lots of seeds bread. But please, as a physician, do not assume what your patient values unless they tell you. And don't assign values that may or may not resonate with the patient's desires to get back to their lifestyle, achieve X, Y, or Z. Maybe all they want to do is be able to walk down the aisle with their daughter, and they are not able to have surgery, and they don't want to limp, and they don't want to feel old. And to them, it's priceless. It's worth all of it. Yes, Dr. Scheinkop, take you off mute.
All right. Am I off mute?
You are.
All right. So several additions. My favorite question is, yes, it costs money. How much did that tattoo cost you? The tattoo on your shoulder, on your leg. It's probably less than the cost of having care for your arthritic joint. Number two,
Right.
there are increasing number of companies that are self-insured that will cover regenerative medicine. So if the patient will go back and ask their employer, they're going to find more often than not it is covered. For instance, several companies such as Land's End has just added the cost and the coverage of regenerative medicine to their host of what they'll pay for. Number three, some people have medical savings accounts that'll pay for this. And then there's the co-pays of a total joint replacement. This is a bargain compared to what's being charged out there for joint replacements, especially when doctors will not accept insurance And you could postpone, maybe avoid a joint replacement by a minimal investment compared to the copay or what you're going to have to shell out of pocket for a total joint.
Absolutely. Absolutely. And, the other thing that I remind physicians is that, and I think we forget this, and we're not used to talking about insurance, and we're always like, oh, go talk to the insurance, person at the front, is that there's an increasing number of patients whose deductible is quite high. $5,000 deductible, $7,500 deductible, $10,000 deductible, which means they have to spend $10,000 before the insurance even kicks in. So if you can come in underneath their deductible, you're actually saving them money. So really, I think, it's always going to be a give and take. And at the end of the day, if you think this is a valuable treatment, I think you'd be remiss to not talk about it, to assume they can't afford it. You never know. I've been shocked more times than I can tell you, So I think that my favorite thing is to do is tell them the right diagnosis, give them every single treatment option, and tell them, I think for what your goal is, because that's what we're doing, is we're trying to help them achieve their goals. For what your goal is, I think this is probably the best option. But, you tell me what you're thinking and how you're feeling and what questions I can help you understand to get to the right the right treatment option for you. Ultimately, they always ask me what I do on my, what would you do? And so I share with them, the joke for me is I pay my parents in PRP and MFAT if you saw that video, the adipose harvest, that's actually my dad getting MFAT. He was kind enough to let me film it, but ultimately, that's what I would do for my family. That's what I would do for myself. And all things being equal, if money was no issue, what would you suggest? And 10 out of 10 physicians go, oh my gosh, hands down, I would choose regenerative medicine. If that's true, then why are you not offering it to your patients? All right.
I was just going to say, we can go ahead and go into some of the questions because I think some of them apply to what you guys have been discussing here. So,
Absolutely.
yeah, so we had somebody that had mentioned on consent forms, can you put that you're injecting stem cells? Can you talk to your patient and tell them that you're injecting stem cells? I think that when people are getting started, that's a big question. How do they handle that?
Absolutely. Dr. Schreinkop, you have some recommendations.
Yeah. In your office, you could talk about stem cells. In your office with the patients, you may talk about stem cells. In print and in marketing, don't do it. You're waving, and don't do it on your website. With the patient, one-on-one, yes, you could do it.
Yeah, and I've actually taken it a step further, and I help redefine what that is, and I call it cellular therapy. Whether it's adipose therapy or bone marrow concentrate, those are all lumped for me when I explain it to my patient under the cellular therapy category. And I do tell them, I'm sure you've heard something like the stem cell procedure, and this is what we're talking about, a stem cell type procedure using cellular therapy, your cells to help affect change and repair. And so, but you're right, don't put it on your website. Please, please, please don't put it on your website. They have bot crawlers looking at the just trolling the internet, and if it flags stem cell, then they're going to start looking at you with more scrutiny. So please don't put that on there. But yes, you're absolutely correct. With your patients, you can have that discussion. I would not put it on my consent. I would say exactly what you're injecting. This is microfragmented adipose tissue. This is, bone marrow concentrate injectate. This is platelet-rich plasma with protein concentrate injection. I would just spell it out. I wouldn't say, because unless you're doing a CFUF, you can't actually say that you're injecting stem cells without looking at it. So I wouldn't get into trouble with doing that.
Okay, perfect. I think you had saw the one about pre and post patient protocols. So is it something similar that you would have with a PRP or PC injection? What does that look like for your patients?
Yeah, so the question is do you have pre and post patient protocols? And are they similar to the PRP when you're treating with MFAT? And for the most part, in my practice, my pre-injection protocols are very similar. We really try to optimize our patient, make sure they're eating a clean diet, you know, making sure, and I always tell them, hey, listen, you're the pharmacy. I'm taking your cells. I need to make sure that we're optimizing your cellular health. So we use diet, we use exercise, no smoking, no alcohol use. I know it's super boring. And then we do limit the anti-inflammatories, especially from the microfat perspective, from a bleeding perspective, right? Because we're using tumescence and we don't want to have excessive bleeding. And so we limit any of those blood thinners, just like a surgical procedure, and we limit the anti-inflammatories for the tumescence and adipose harvesting procedure. After the adipose harvesting, I do use an abdominal binder. That's twofold. One is to compress the site to decrease any bleeding or bruising and swelling. And number two, to give them a little support. It seems to be more comfortable to have a little abdominal binder for them just for a couple of days. That seems to be much better tolerated. And then from an injectate perspective, absolutely, we use our standard post-orthobiologic injection protocols, taking into account, do we need to protect them at all? Are they at high risk for injury? And for the most part, the reason we're using those orthobiologics is because we don't have to protect surgical repairs. Sometimes we do this perioperatively, but for the majority of these injection-based therapies, this is instead of surgery. And so those tissues are amenable to injection and they are secure or stable enough to be able to tolerate normal activities, maybe not go into sport and that kind of thing, but all your activities of daily living, maybe a couple of days of downtime to allow some inflammatory response to happen.
All right, I'm going to interject something. Okay?
Absolutely. I was just going to ask you for your opinion.
Prehabilitation on all patients to maximize range of motion and strength prior to the procedure. Post-treatment at some time, 10 to 14 days, physical therapy thereafter. One, it maximizes and benefits, maximizes results, and gives you continuous feedback from the therapist to you as to whether the patient is progressing, whether they need to come in earlier than 12 weeks or 6 weeks, whatever you're doing. And you'll have a continuum of monitoring from a third person, and it'll maximize your results as well.
Perfect.
Yeah, absolutely. I also add to my post-operative protocol, we have added laser to all of my post injection patients to stimulate the mitochondria and rev up that the reparative process. So we have some questions. Should I tell my malpractice carrier I am doing MFAT? And if they ask if it is stem cells, what should I say? Malpractice is a little interesting. I would not say stem cells because that's not what you're doing. You're doing a lipoaspirate and you're doing microfragmented adipose injection-based therapies. And that's what you're doing. And for the majority of physicians, I have not seen, and I've talked to a bunch of them, and they're like, oh, okay, cool, that's great. Whether it's PRP or bone marrow concentrate, you can kind of lump those all into orthobiologic injection under sound guidance. Let's see here. let's see here. Let's see. Can we use fluoroscopy instead of ultrasound during injection? Yeah, I mean, our recommendation for
No
injection
response
is
from Papa.
guided therapy.
That's for a phone call, but yeah.
Oops, we have somebody talking.
I think I just muted where it
Oh,
was coming.
perfect.
Yep.
Okay, perfect. Thank you. Yeah, so guidance for injection is perfect. I think that it just is much more precise as to where you're going. And for me, I use ultrasound quite frequently, but in certain applications, such as hip, I use ultrasound and fluoroscopy to confirm. So absolutely, guidance is really recommended for the injection to be really sure you know exactly where you're going. You know, I get this argument a lot, like, oh, I know where the joint is. And what we found in our research is, yes, you do about 80% of the time. And if I'm going to be charging for, you know, a good amount of money to get these in the exact perfect place, I'm going to use every tool that I have in my tool belt to make sure that I'm 100% sure I know exactly where this injectate is going.
We did have a question come in that wants to understand, when would you use adipose versus PRP versus bone marrow concentrate?
Sure, sure. Dr. Steinkup, do you have
Yeah.
a perspective on that?
Yes, this whole field is in a state of flux.
Mhm.
PRP is being re-identified now as a minimum of 5 billion platelets to get results. So you need a super concentrated, and I prefer leukocyte-rich approach. That's one. Two, bone marrow concentrate has a place, but we're finding more and more that MFAT, especially in the shoulder, is really great. And I have some colleagues on the West Coast that are taking care of an ever increasing number of golfers and tennis players because of the results that they're getting with MFAT in the shoulder, in the incomplete tear of the rotator cuff, especially. Now, as it may well be at this time, bone marrow concentrate is still the standard of care. We're redefining it. We have to do outcome comparisons, but there's so many opportunities for MFAT when you reject the patient for bone marrow concentrate. You're not going to do a bone marrow concentrate on a grade 4 osteoarthritic knee. But if the patient has a reasonable range of motion and is quite functional, MFAT can buy time before the total joint replacement. The same in the hip. It's not as good. Nothing is as good in the knee. I mean, nothing is as good in the hip as it is in the knee or shoulder. Hip is still a problem we haven't solved. The hip people come in too late in the cycle of arthritis. Knee and shoulder people come in earlier. But I think we are able to say, at least Dr. Demers and I agree, that MFAT is reaching a level that we could offer it equally with platelet-rich plasma, which should be 3 injections in 6 to 12 weeks of super concentrated leukocyte-rich platelets or bone marrow concentrate MFAT. I love MFAT when I can't use bone marrow concentrate or PRP. I use MFAT when I want to take care of several joints. And I use MFAT when the patient comes back up and says, hey, this hasn't worked. I'm not satisfied.
Yeah, absolutely. I would just add to that. Sometimes I like to try to think about MFAT in places where I would like a scaffold, where I want it to stay put and give us a scaffold, specifically in that rotator cuff, where I'm doing intratendinous injections in these high-grade partial thickness tears, and I want it to stay exactly there. Or intrameniscal, when I want that injectate to stay right in the tear, and I don't want it to flow like PRP or bone marrow. Preferentially, if I'm going to be using intraosseous, I use bone marrow concentrate for those bone marrow lesions. And I think we can agree that platelet-rich plasma is a workhorse and does a lot of work. It, I think, underperforms in high-grade disease, those grade 4 chondromalacia, the high-grade partial thickness tears. So I would reserve those for lower grade disease, if that makes sense. Let's see here. Do we have any issues with having contrast or lidocaine in the area of the injection? That's a great question, and this has been controversial, although recently there's been a number of studies that have shown that the dilute contrast, dilute local anesthetic has not been detrimental to cellular health. And there's even a study that 1% lidocaine has not been detrimental to cellular health when used in conjunction with the bone marrow concentrate. That being said, I would prefer to go with a dilute solution of the injectate. So, you know, the either 0.125% lidocaine or 0.125% ropivacaine. Bupivacaine has been shown to be cytotoxic, so if you can avoid that, that would be great. I still really do avoid any intra-articular anesthetic. I think you're just kind of playing with fire there, because the chondrocytes are so finicky and they're, you know, they don't do well in general. Their cellular metabolism is quite low, and it's a different environment.
So let me interject something.
Yeah, absolutely.
I noticed that I would do an intra-articular injection, be it with MFAT, be it the hip or the knee or the shoulder, and the patients would walk out and say, "Doc, the pain's gone." And it more likely than not is the A2M content of these orthobiologics. They afford some kind of instantaneous pain relief by blocking the pain messengers and the inflammatory state in the joints. So there is no reason to put any of these locals intra-articular when you're putting biologics. You could put local in the skin, subcutaneous tissue, stop there. No reason to put it into a joint and to take the risk of killing off the cells that you're injecting into an area.
Yeah. And honestly, I use a lot of regional anesthetic. I think that plays really, really nicely because when you're using MFAT, you do have to inject in from a larger bore needle, so 18 or 21 gauge needle. And a lot of times that's not super comfortable. And so a local and or a regional anesthetic kind of is the best of both worlds because you don't have to have local anesthetic in the field, but yet you have a really nice pain relief during the procedure when you're using larger bore needles. Oh, there was a question. I wonder if we could do the info on the study again. Maybe the knee study. Was it the knee study or the shoulder study? I'm happy to share the shoulder study. I'm very familiar with that data. The knee study is Dr. Scheinkopf's baby, so maybe we can clarify. Maybe the knee study was what he was looking for, just because there was a little bit of a lag on
If we
the.
could go back to that slide.
Yeah, we'll just go back to the slide with the knee data, and I think that'll be helpful for us. Let's see if we can get that.
Question. So tell me the question.
Yeah, they just asked, can you go into the info on that study again?
Okay.
So maybe just do a quick little.
So there were 36 patients treated with an average of 9.4 millimeters of MFAT injected per joint. While there were 36 patients, there were 48 joints because obviously 12 knees were bilateral. In 12 patients, synovial fluid was aspirated at 1 month, and in 9 patients at 2 and 3 months. All patients were assessed using pain scores, function scores, WOMAC scores, and walking distance, 6-minute walking distance at 1, 3, and 6 months. The average dose total nucleated cells content delivered with MFAT was 9 million per injection. 50% decrease observed in the VAS at 1 month, which decreased further by 68% at 6 months. So that's statistically significant. The Coos Junior score increased 17% at 1 month and 39% at 6 months. Again, statistically significant. The WOMAC improved 78% at 1 month, statistically significant, and remained constant during the study. The 6-minute walking distance continued to improve over the course of the study. So there you are.
Dr. Steincup, can you just forward to that lovely paper that kind of gave a big, yeah, if you'll just stay there, I think that's one of the ones that they really wanted to reference, to be able to reference. So everybody who wants to take a look at this kind of history of MFAT, a narrative review that was really nicely put together by yourself and the above.
The cats and the cats family.
Yes, absolutely. Absolutely. Perfect. I think that we have a couple questions. One was, can we do some light general sedation? I think that's not required. This, number one, the tumescence anesthesia is very effective. And then a regional anesthetic or just even local anesthetic for an intra-articular injection is really all that you need. So it may be a bit much, a bit of overkill.
And a suggestion, don't look for trouble. You're doing this in the office. There's
Right.
no reason to do anything more than local. It works great in 99% of patients. They're not confused. They're not sick. They understand what's happening. You could communicate with them, and you avoid comorbidities of complications of intravenous sedation.
Right. Yeah, absolutely. And then we have a couple other questions. Do we have any studies for spine or facet or epidural? I do know that there are some physicians doing facet and extra epidural injections. I don't believe we have any current use of MFAT for epidural use at this point, but maybe Nathan can chime in a little bit on that. And then I think there's a couple more. Yeah. And then there was one question, and I think this is a great question. Is there imaging data to support improvement in the biology of the soft tissue pre and post dose? So I think at this point, we don't have many studies showing pre and post MRI. Hopefully at the 2-year mark of the shoulder data, we'll be able to collect the MRI findings as well. And I know that we have some case reports that have shown significant healing with MFAT application to high-grade rotator cuff tissue. And so, and then from my own experience, I would concur with that as well. But I think we're not fully there. Dr. Steinkoff?
At this point, we're looking at functional improvements.
Right.
We don't have the economic resources to repeat the MRI and get the patient to cooperate to go back in and do the trial, especially it's coming out of their pockets. But we can have office reassessments. So we have patient-reported outcomes on the one hand, but we do have increasing data as far as functional improvement. And that we can suggest is our metric for success.
Right. I think, there's an increasing push for patient-reported outcomes as the most important thing to look at. But I also understand that we want to know if we are able to actually affect repair and talk about that. And I do know that there are some studies out there we're working that way. I don't think we haven't done all of that yet from a financial issue for the most part. Oops.
Actually, I can
I
add
want to remind is this as an adjunct to every other form of reparative treatment, surgery. The MFAT as an adjunct. If you're undertaking an arthroscopic repair of any kind, ACL, rotator cuff, whatever, it's a wonderful way to hasten healing, diminish pain, speed up rehabilitation. Okay, Nathan, I'm done.
Hi, Nathan. Do we have
Yes, hi.
some data?
There was a couple questions specific to mechanism of action and the what we can say about. So first of all, we do collecting data as you know about the synovial fluid cytokine panel following the injection as a baseline, and then follow up 1, 3, 6 months. Second, there is ongoing study including MRI, just baseline and then 6 months. It just the group study is just too small to present it. And the last point that I wanted to bring up, there was a question about anti-inflammatory or regenerative effect of this treatment. So we did study in Russian University that showing that there is a proteoglycan synthesis in cartilage, which showing the regenerative effect, or at least preservation of the cartilage due to this, again, proteoglycan synthesis that induced by the cells. So we can actually stand behind this claim.
Great, great. Yeah, it's so fascinating. And I think we're at this inflection point in this field of orthobiologics where we are really getting a good handle on exactly how these things are working and what applications are helpful and how exactly to be using these injectates, whether for inflammatory or structural or scaffold or limited disease versus more significant disease. So definitely, we need to stay tuned, and we are absolutely working tirelessly to try to find those answers for our patients and for our fellow physicians as well.
Well, that was wonderful. Thank you, guys. I think out of respect for everybody's time, I know this has been great information. We're going to go ahead and close our Q&A. But again, thank you, Dr. Scheinkopf, Dr. Demers, Dr. Katz, for all the invaluable information on adipose tissue, techniques, evidence, and of course, patient discussions. We are excited to announce that we are now offering monthly Sunday labs for lipoaspirate training, bone marrow harvest training, as well as PRP and protein concentrate. Fantastic opportunity to learn more on techniques from Dr. Demers. I think Dr. Katz is going to be attending whenever he can. Best of all, there is no charge to register. So we do ask that you register at least 1 week in advance because we will have to put a cap on it at a certain point. So again, thank you for joining us for this interactive session. To try MiniTC on a patient, please scan the QR code that you see on your screen, and we will ensure a member of our clinical education team comes to you with the necessary supplies for our patient treatment. With that said, thank you again for joining us. Thank you to our panel. Again, great information, and everybody have a fantastic evening.
Thanks so much.